I am Dr. Kiran. These are my credentials as you can see on the slide. I'm going to talk about cauda equina syndrome, which is of two types. One is the acute and sudden type, which is a catastrophe, very difficult to recover from. In my opinion, this slow form of cauda equina compression is being missed by specialties who ever see a low backache patient. See, when I come to an orthopedic surgeon or a neurosurgeon for a low back pain, I will say, sir, I have low back pain, sir. And he may ask, is it radiating into your lower limb? I'll say yes or no. If he doesn't ask me about whether I am able to pass my urine, for a normal common man, he will think, why is this doctor talking about sex? Why is he talking about urination, passing stools? Please, it's the human body. Sexual dysfunctions, one of the main causes of depression and people getting isolated, or they're being accused of without giving a thought, what is happening to this person? Why is he suffering? Why am I accusing like that? Their marriages being broken. Their years of marital understanding getting spoiled because the female or the male suspects the other partner is lost interest in the other partner. Practically, health-wise also there will be a factor. I'm not blaming the partners. They have some discord is there, some misunderstanding and some problems. But I have seen people accusing the other, saying that you have lost interest in me. No, I have known these stories. People come and tell me, because why? Because I ask. Write an MRI, write an X-ray, physiotherapy, go. No. There is something always beyond. So with this, let me start talking about cauda equina syndrome, the acute and sudden form, which is sudden. Suddenly the patient is paralyzed, legs will not work, male or female, urine incontinence, no control over urine, no control over the sphincter. Morning at toilet, it will be a mistake he or she has done is neglected her disc. Not only a disc, it can be a tumor, it can be a fracture, anything. So acute forms are an emergency it's as soon as possible, at the earliest, surgical decompression is done without a promise of recovery. Where the cauda equina begins at the lower border of L1, it can sometimes be upper border, lower border, even L2. Cauda equina, tail of a horse, that is what is described here in my slide I am showing you. Here you can see it. The tail of a horse which exit gradually at each level. There will be two nerves that are passing at each disc. There are two nerves which are passing at each disc. It may be one nerve can be split and be 2 or 3 or 4, we never know. Like you see externally, we see small kids with a gap in the lip. We see, it's a cleft lip case. What about what is going on inside? A nerve can be in 2 or 3 bundles, not single. And we are talking about a whole cauda equina, nerves going down vertically down. And if each nerve is duplicated, we get confused during surgery. These are the points for the youngsters reading orthopedics. Expect the unexpected when you put a knife in. You are the safest surgeon. The incidence of CES, cauda equina syndrome, is between 1 in 33,000 to 1 in 1 lakh. But this much range is an ambiguity according to literature itself. Why? This 1 in 33,000 to 1 in 1 lakh is the tip of the iceberg. The iceberg which is above the water. Now below the water, we have the laborers. We have the low income group people, middle income group people, even the rich. Some of them are rich, but they're not educated, or they don't have the academic and medical knowledge to relate their lumbago, low backache. 99% or 99.99% of the low backache patients are not aware that they can get paralyzed. Even if they know, there is a tendency to neglect. There is a very big tendency to disregard a doctor who's trying to tell them, you will be paralyzed, please get the surgery done. No, doctor, I will have to go to work, doctor. Doctor, I am going to India, I will come back and do it. Doctor, I have some work, I have a marriage for somebody, I will go attend and come back to you, sir. They don't come back for follow-up. Whose loss is it when a patient disregards, disobeys, does not trust a doctor who cares for them? Because especially if it is happening to a person who's lifting weights every day. For example, I see laborers lifting cement beams. When you know that is the pressure they're putting on their spine, why won't the disc cause damage? A disc has come out and one person is neglecting it. How long can the spine take it? Suppose my neck is the spinal cord, and something is something pushing me down. Won't my neck, the posterior, the behind part of the neck, spinal cord, or in the lumbar spinal cord be compressed, where fibers of sensory system is going to the brain. If this switch is not working, this light won't work. The switch, as long as it's not repaired, it will not work. Bulb won't glow. So once the nerve is damaged, especially a neural, why do you think that stroke patients do not recover properly? Some residual hand will not move, leg will not, they will walk like this. Why? If it recovers like any other structure, liver regenerates very nicely, but not a nerve. So we cannot afford to neglect a cauda equina syndrome which is impending. There are two forms, like I said. Acute form, which suddenly happens, especially in these kind of the persons who lift or do manual labor, suddenly it may come. And they say it's relatively rare. How? I have seen 4 or 5 cases, maybe in a span of 3 months when I worked in a very heavy trauma center. Now I am going to concentrate on the slow form, which is much more dangerous. Every 1 month, one patient was coming. First day he was coming and saying, lumbago doctor, some back pain doctor. I saw the MRI and said, you have 90% of his spinal cord is compressed. You must go for a surgery. He says, no doctor, I'll come. Then after 3 months he comes. Doctor, I'm not able to control my urine. I just watched him. His groin was all wet. I said, you are going into paralysis, cauda equina, do it. I'll come with my attendant and friends, doctor. 2 months later he comes. He comes like this. Doctor, I'm not able to walk. This is a true story. Mind you, true story, my friends. He was coming like this. I said, why? What? You're getting paralyzed, man. Come on, you at least now do it. I'm afraid, doctor. He signed on our documents, because these are the kind of patients who allege that the doctor has not done a surgery properly, or after his surgery he got paralyzed. And finally, one day he was carried by his co-workers, fully paralyzed. My experience, I take video consents. I don't take normal, I take video consents, because human beings lie a lot. So video documentation after his written consent. From the first visit I am keeping a track record, and then after he got paralyzed, he calls all his friends and says that doctor operated, I got paralyzed. And actually there'll be an uproar. They came on to me. Then I said, please sit down, and showed all the videos. They said, sorry sir, we never thought our colleague will do this. And they all dispersed. But the mental trauma for the surgeon who is really caring and loving his patient is enormous. A surgeon will do surgeries, whether we get a good compliment or a backlash. We are chosen by God. In my experience, one more patient came. She had severe lumbago, not able to stand properly. Her complaint was, doctor, I have lumbago for several years. Recently I am developing urinary bladder weakness. It's embarrassing, doctor. When I go to office, I have to run to the loo. I can't control. Till I go to the loo, I am already wetting my innards. So I took an MRI. Lumbar was all right. I didn't understand. Even experienced, I'm 22 years, experienced orthopedic surgeon. I didn't understand why the lumbar spine is okay. When I just watched down, the sacrum, which is like this, like a plate, a bent plate, okay? The sacrum was pushed. There was a gap, and we call it scalloping radiologically. Scalloping is, you scallop an ice cream. You have a special spoon. Tarlow's cyst. What is Tarlow's cyst? Tarlov''s cyst. It's a perineural cyst. Every patient actually teaches the orthopedic surgeon, neurosurgeon. My only advice is, when you see a Tarlow's cyst, please do not neglect it. It can cause paralysis, like this patient is going into. Please refer to a competent person who has done decompression of Tarlow's cyst, because they are very difficult. It needs a lot of surgery there around. It need not be in the sacrum alone. It can be upper also, in the lumbar region, anywhere in the spine. It's a perineural cyst. A cyst around the perineural sheath, and they should be competent to suture it back after decompressing and educate the patient that these cysts can recur. Otherwise, there will be a case on the doctor. I referred her to a neurosurgeon. Whether she did the surgery or not, I don't know. So after 4 months, I met her at a zebra crossing at a signal. Doctor, how are you? She was very nice. I said, what happened, ma'am? How are you? Did you get the surgery done? No, doctor. I said, ma'am, what are you doing? Doctor, we'll see, doctor. Fear. I have my own things which I am afraid of. Why not? I am a human being too. She is a human being too. So respects to her, but it is a dangerous situation. So each lumbago patient must be asked for saddle anesthesia. Saddle anesthesia is the anal region, the buttocks, any anesthesia. Lower limb weakness, bladder control, bowel control, sexual dysfunction, erectile dysfunction, orgasm, which may all get affected in both males and females. Here, I have to tell you one thing. I had a lady, an expat from another country who came to me. When I had a female attendant with me and she was speaking the same language. So I told my assistant to ask her, female assistant to ask her, does she have any sensory deficit or any other problem in her private parts? And she just shouted, I do not know any sensation in my private parts. And that too in English. I was so surprised, taken back, and I said, ma'am, why did you burst out like that? Doctor, you are the first one who's asking me this. Now I am relieved because I didn't know whom to go and ask this question. I want to just commit suicide. See, this is what we are supposed to ask. Everything. So when you do a MRI, it shows the total cutoff of the CSF on the MRI section.
When a cauda equina nerve is being compressed, how many forces can come into play? Twisting, torsional forces, longitudinal forces, shearing forces, shear or compression forces. So many forces come into play, damaging the nerve. So how can one expect a cauda equina syndrome to recover properly and go to courts against the surgeon who is dealing with it? Because orthopedics is the second most worldwide, second most sued department. So the legal advocates and the courts must also understand that a person with cauda equina syndrome will not have a good prognosis. Lastly, the health authorities around the world make the insurance companies answerable for the delay in approving these surgical procedures. They are equally responsible. If something has happened to the patient, the doctor alone is not answerable. The ICD code 83.4 is given to highlight cauda equina syndrome. Why? So that the coders, the hospital management, the insurance companies are notified that this patient is suffering from an emergency. The reality, the insurance companies are delaying the emergency treatment to be given to the patient as an emergency by putting queries and asking for various kinds of explanations, which means who is affected? Patient. Knowing very well that a nerve once damaged will not regenerate properly. So, is a food for thought for all the administrative staff in every department. Doctor is helpless. And the radiologist reports must be uniform, in a uniform international pro forma. No excuses. They should mention everything. I have seen some reports, so beautiful radiology reports. How much is the diameter at the interneurovertebral foramen? How much is the spinal canal diameter? How much is the disc? What is the stage is it in? What is the thickening? How many mm is the ligamentum flavum thickened? These are beautiful reports which we want. People are not even labeling L1, L2, L3, L4, L5. They're not labeling. So at a random when we check, we don't know which vertebrae we are seeing. It takes a lot of wastage of clinicians' time to do all that. They're supposed to label each level. I see such MRI reports. Thank you so much. So I'll come to the conclusion. A spinal canal with the risk of impending cauda equina syndrome is better decompressed early, which is a safer option. Normal discs, we can wait. Bulge, protrusion, we can wait. Once it is extruded or sequestrated, don't wait. They are the indications for surgery. They are totally, the annulus has herniated, opened up, and the disc is out. Anything can happen all of a sudden because the patient is mobile. He's not a doll who sticks like this. He does this, he does this, she does this, she does that, everything, rotations in everyday life. So we cannot afford to postpone.